and my own convener, Dr. Nisha, all seniors, and all my dear friends and house surgeons who have joined us today on this platform. A warm welcome to one and all. Today we have a very meticulously selected topic, especially for the house surgeons, for the prompt diagnosis and management of newborns. So, how to recognize the danger signals in newborns. So, first and foremost, I would like to welcome our president who have joined us today on this platform, in spite of his busy OB meetings, and welcome you, sir. I welcome the chief guest of the day, Manoj VC, sir, the National NNF president, who again had a lot of meetings and readily agreed to me to be the chief guest today and give an address. Thank you, sir.
Thank you.
I welcome our faculty, Dr. Naveen Jain, sir, to this program. I welcome the state office bearers, Dr. Gopi Mohan, Dr. Pinukutan, Dr. Ranjit, and my convener, Dr. Nisha, who again today has got a very good um, opportunity, and she has cleared her DM cardio at Jayadeva Institute, and now she is going to be the chairperson, I think, of the cardiology chapter soon of our IAP Kerala. So again, welcome Dr. Nisha, and welcome all the senior IAPians, dear colleagues, and all the house surgeons who have joined on this platform. Thank you all. Over to you, Nisha.
Thank you, sir. Now I invite our dear President, Dr. Riaz, sir, for the presentation.
Thank you, Dr. Nisha. Our faculty for the day, Dr. Naveen, our pride and our prestige, Dr. Manoj, who is the national president of NNF, the torch bearers of this particular program, Dr. Joni and Dr. Nisha, my dear friends, Dr. Gopi, Dr. Ranjit, as well as we have a few guests from our neighboring state, Shingarivellu sir and Jalil sir. They join most of our academic programs, be it for PGs or practitioners or house surgeons, and everyone in the platform, and my dear students. Actually, the need for special training for house surgeons, I was the most convinced when I was posted at Idiki for a short period, because when you are having a lot of postgraduates around, we won't know the importance of the house surgeons. But a trained house surgeon is very, very important in a hospital where there are no postgraduates and there are no other junior pediatricians or someone. Because most of the time, they will be the people who will be called in as the first line. So it's a very apt topic, that is identifying and stabilizing a sick newborn is very important, and that should be learned by each of you. And today you have the best faculty you can have in this particular topic. And Dr. Naveen is my senior, and he is actually our pride as a teacher, as a mentor. And I need not introduce him much because you will know what he is when he is taking the class. So with that introduction, I give back my mic to Dr. Nisha. Everyone please mute. Everyone please keep your mics muted. Over to Nisha.
Thank you, sir. Now we have our National Neonatology Forum President, Dr. Manoj, sir, with us. I invite sir to address the gathering.
Respected seniors and my dear friends, I bring warm greetings from the National Neonatology Forum. I'm not sure if the house surgeons in this group know, but NNF and IAP have always been at the forefront, leading the struggle of all doctors right from your internship days to stay updated in the knowledge and skills. It's continuously evolving. The treatment protocols are actually evolving so fast. So to take care of neonates, we need to actually evolve ourselves. I remember my internship days.
Sorry, sir. Please continue.
Yeah. Now, almost 35 years ago, when like we as house surgeons used to do everything, and then we used to even do cesarean sections under supervision and all. But those days are gone. Now, this training is important because we have more people, and so the skill that is important comes down. And on the other side, neonatology, from merely focusing on survival, it has moved on to intact survival of tiniest babies. And now our aim has even grown further to help these babies evolve into children and realize their full potential as adults free from lifestyle diseases. So it is a great change that is happening. So you should keep yourself updated. For that, knowing the basics is very important. We at NNF and also at IAP believe in bridging the gap between what you learn and what you practice. That's why I'm so happy to see IAP Kerala under Dr. Ria's undertaking to take up this program Ignite tips with this objective in mind. Congratulations, the whole team, Doctors Riaz, Joni, Nisha, and the whole team of IAP Kerala for doing this. This is a great service, and training the house surgeons is something, like that is going to pay rich dividends. Sincerely, I wish all the success for this initiative. I'm sure that it is going to be one of the greatest programs that IAP Kerala has done, if it is going to go in the same thing. And then today we are going to learn something and from the master of the masters, my dear friend Naveen. So I will not waste any more time. Let's straight away go on to that. Over to you, Nisha. Thank you.
Thank you, sir. Now we'll be proceeding to the academic section. So the topic is neonatal red flags assessment and stabilization. I am extremely happy to invite Dr. Naveen Jain, sir, who is HOD Neonatology, KIMS Trivandrum. Sir is one of the most sought after neonatology trainers, and sir had his DM neonatology training in PGI Chandigarh and is working in KIMS for many years, and he has trained many neonatologists and also MD pediatricians, so many DNB trainees. Okay, sir. So over to Naveen James.
Thank you, Nisha, and Manoj, Riaz, who are all more friends than office bearers, actually. I have a confession to make that what I'm going to present today is not just used by interns or house officers, by our postgraduates, consultants across. We call it a uniform language. Imagine if I started speaking to you in Hindi, Telugu, you would not understand what we are speaking. So one of the most important things when we are dealing with sick babies, children, adults, is to have a uniform language for everyone, nurses, the residents, the doctors. If somebody picks up the phone and calls you, can you please tell me how is this baby? And you respond to Nisha or Manoj or Riaz or to Dr. Johnny or Sringavalu, sir, it should be the same language. And therefore, please, you will note that what I'm going to present is explicitly simple, but this is what we have been practicing for ever since now. So I'll just get back. I just hope I am sharing correctly.
Sir,
Yeah.
sir, 1 minute. The Joni or Ranjit, please share the YouTube link also, because the Zoom is full. You can.
No, it's already there in YouTube.
Yeah. Okay. So the house surgeons can share the YouTube link to your friends.
Yep. So thank you, Riaz. And if there is only one slide that I had to present, this would be it. Stops is what we are going to learn throughout the next 15 minutes. At the end of seeing a newborn baby, whether you see the baby in OPD, you see the baby in labor room, in the ICU, anywhere, before you move on from this baby to the next one, we have to classify this baby as being well or sick. And in fact, babies are much easier to evaluate than children and adults. When we took up pediatrics, we were told that babies can't give history and therefore they are very difficult to evaluate. By the next 15 minutes, you will realize that this is not a true fact. Now, the first part of this S is called a sensorium. The second T is called temperature. O is oxygenation. P is perfusion. And S is sugars. We'll keep running through an example and you will find that each slide is going to see only these 5 letters. What do we mean by a good sensorium in a baby? Unlike us who have a sleep-wake cycle of around 24 hours, I would fall asleep today night at 10:30 and get up at 6 a.m. Even if I didn't sleep till 12:30, I'll still get up at 6 a.m. There is a biological clock in my head. The babies have a biological clock of about 4 to 5 hours, not 24 hours like us. So after every 4 to 5 hours, a baby should wake up. He should look around like that. He should make some movements. Baby would cry. And the baby would lie flexed in a good tone like this. So if all these are there, then it's an active baby. A baby who is sleeping when you see and having a low tone like this doesn't respond to removing the covers, switching on a light, by the conversation the team is making near the baby, does not make efforts to cry, is a lethargic baby. Now look at this. If this baby was in the ICU, our nursing team would have an opportunity to record in their chart this particular vital sign. And if your unit is not having this vital sign, I would request you to add this column, which is very different from the pediatric and adult vital signs where they have only heart rate, blood pressure, sugars, is this item called sensorium. At the end of the day, when you look at your friend in the room, in the ward, in 1 second you can tell, Eda, you are not looking okay. Or something is very special today. Did you find a girlfriend or a boyfriend? So that look on the face can tell everything because whatever vitals are there in your body, they're working towards keeping your brain healthy. If everything goes wrong, then also the body will compensate so that the oxygen will go, glucose will go, blood flow will go to the brain and keep it critically healthy till everything goes uncorrectable. So a healthy baby might sleep for, like I told you, 3 to 4 hours. So when you come at 7 a.m. if the baby is sleeping and the nurses record lethargic, 8, 9, but 10 a.m. the baby woke up, looked around, cried, made movements, good, sensorium is good. And then again went to sleep and then again got up after some time. So this would be an active baby who has a normal tone, is flexed like this, responsive to touch, has a good cry and spontaneous movement. So if a baby came to the OPD and mother said, oh, Bhayangara Shardila, this baby is vomiting too much, this baby is crying all the day, and you find the baby is in mother's hands with a good flexion tone. When you uncover the baby, he starts moving, he starts trying to cry, and baby is responding by looking around. In my OPD, which I did today also, after 25 years of doing the same job every day, this baby would be marked as okay. After that, whatever this mother is telling me, is just information. But I have already made up my mind that this baby is okay. Whereas a sick baby would be not waking up. Often my nurses would go to the next ICU room and call me saying that, sir, this baby has been sleeping without waking up, without crying for last 6 hours. I am telling the resident that baby is not okay, and he feels that blood gas is okay, X-ray is okay. He is not responding to my request. I wanted to inform you that baby is sick. And often these babies are extremely unwell. If 4 hours, 5 hours have elapsed and this baby has not started moving, crying, and trying to respond to signals from outside. In fact, this applies to even the smallest babies, even 25, 26 weeks babies on second, third day of life also would show a waking up, moving, and even if they're intubated on ventilator, then also they would wake up and cry and make some responses. So if a baby is crying, not moving for more than 4 hours, it would make me concerned. A baby who is floppy with poor tone, poor responses to touch, being uncovered, poor cry, and decreased movements is a baby who is definitely not having a good sensorium. So more than 6 hours baby has been sleeping, I would evaluate more carefully the rest of the tops from the stops. Look at the temperature. Is the baby cold? Is that why he is not responding? Is his oxygenation not okay? Perfusion not okay, or sugar is not okay? If all these are okay, then I would start thinking something's wrong here in the brain per se. Is this baby having an asphyxia, an intracranial bleed, or meningitis? And I would consider doing a CSF examination, sodium test, because hyponatremia can cause them to sleep, ammonia, or imaging, and these would be looking at primarily brain conditions, because if the tops are okay, baby should be active. So the second vital sign is temperature. And temperature in newborn, if somebody asks you what is the temperature, please don't tell what is the axillary temperature. That is meant to be maintained. Before that falls, the baby's peripheries would go cold. And for residents who are not doing pediatrics already, our body tries to conserve the heat so that we are okay. Our core temperature remains normal. All enzymes keep working. So if our environment is too cold, or if the baby is sick and not producing enough energy, then baby wants to keep this for the core functions of the brain, heart, adrenals, kidneys. And what is not useful is the skin, is the muscle, and therefore blood flow to these areas would decrease, and the hands and feet would go cold. So when we were residents in PGI and we had to see something like 35, 40 babies in 1 hour and call our consultant to tell what is happening in the ICU, all we would do use the dorsum of our hand, touch the feet of each baby. If it was warm, we decided that we will report this baby as healthy. Then we will come back and do detailed assessment of X-ray, blood gas, whatever we want. But you can go in simple language, whether it is elderly people or babies. If you touch their feet, your babies will be safe. So touch the feet with the dorsum of your hand and it should feel as warm as the abdomen. If that is the case, baby is okay. So this is showing how you touch the baby of the feet of the baby with the dorsum of your hand. If the baby's temperature on the periphery is cold, first make sure the room is not too cold. Babies are half like fish. If the room become cold. And this is done by keeping room thermometers in the ICU. Remove wet clothes and clothe the baby well. You generally use 2 layers of clothes, a cap, hands and gloves and socks so baby remains warm. So caps, socks, gloves, and 2 layers of clothes. They need not be wool. Babies keep passing motion and urine very frequently, and cleaning and keeping woolen clothes ready again is near to impossible. 2 layers of cotton cloth which traps air in between does the same job as wool does and therefore is just as enough. If the baby was cold, wrap him well, keep him close skin to skin contact with mother if you don't have a radiant warmer, or place him under radiant warmer in the ICU and reassess after 15 minutes. So you can do a kangaroo care where you place the baby skin to skin contact with the mother or under a radiant warmer. After 15 minutes, you see whether the baby has become warm again. If you are inside the NICU, there is a very, very important device you would find that is a warmer, and there is something called a heater output on the warmer. This is the part where you will see the heater output. Now, this heater output is working on a servo mode. It measures the baby temperature. If baby's temperature is matching the set temperature, which you can see 37.1, then the warmer will not produce any heat because it has done the job already. Baby is already warm. But if the baby is colder than 37, then a little heat will be produced. Let us say 36.5. Still baby doesn't become warm, more heat will be produced and more and more. So more heat warmer has to give means that baby is more sick. So if the baby was having less heater output at some point of time, this is how my chart would look in an ICU. Baby is warm, 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 a good baby. Heater output is just about 0 or 25%, 0 or 25%. This means baby is healthy. Whereas a baby whose peripheries are cold, not getting rewarmed, and you can see the heater output remains high, 25, 50, 75. This kind of a baby is very sick, and I would like to rewarm the baby, and in 15 minutes, if things don't improve, I would like to think whether this baby has sepsis, has he got a major health problem. If he's still cold, I will evaluate also for shock and make sure the baby is not very sick. When it comes to the third letter, sensorium, temperature, oxygenation, I would look at the baby's saturation in room air and also look for whether any respiratory distress is there. Respiratory distress will be seen by fast breathing, retractions, and grunting. So a baby whose saturation is more than 90% while on room air is a healthy baby. But if the baby requires some oxygen, these days you will not find these kind of oxy hoods which we used in our days, but I still think they were very useful. We used to call them the poor man's ABG. If you have both the oxyhood ports open, then air and oxygen both are mixing and baby is getting a low oxygen concentration. But this is more than room air, which is 21%. If a baby requires 30% oxygen, he is mildly sick. So you received this baby in emergency room or from labor room and his saturation was 95 on 30% oxygen. You will tell your consultant, look, saturation is okay, but he requires 30% oxygen. After some time, the saturations become 88, 89, and you increase the oxygen concentration by closing one porthole. This baby is even sicker, and a baby who requires 90% oxygen is critically ill. When you look at retractions of the lower sternum and the lower chest wall, and also grunting, you can hear these mean that the baby is extremely sick and needs not just oxygen, he needs pressure support also. So if the baby has retractions or grunt, his treatment is not oxygen, his treatment is pressure. You may start CPAP or you may ventilate the baby depending on the situation. I will not be going to details of that. So now you have the fourth parameter, that is perfusion. Perfusion, you look at capillary refill time, but unlike in pediatric and adult, you are not checking on the hands and feet because they go cold very easily. You check on the forehead or you check on the sternum, just press for 5 seconds, then release and count in your mind 1, 2, 3, or count 1 in 1000, 2 in 1000, 3 in 1000, or count capillary refill time, and by that time briskly the blood should refill into the skin. If it does not refill by 3 seconds, then the baby is not well. A heart rate which is variable in newborns from 120 to 140. More important is to see serial values of heart rate. If they're increasing or decreasing, then there is a concern. So this is demonstrating capillary refill time, and you count 1 in 1000, 2 in 1000, and 3 in 1000, and you check in newborns on sternum or forehead. This is showing a chart of a healthy baby where you can see the refill time was 2, 3, and then suddenly it becomes 4, 4, 4. This is meaning the baby is getting sicker. His perfusion is going down, and his heart rate, which is 130, 140, is going up serially. At this juncture, I would like to remember one of my teachers, Dr. Noel, who was one of the greatest teachers of intensive care. And if a baby became sick and died, or a child became sick and died, he would simply pick up the chart like this, and he could easily show us the point where worsening started on the chart, where you can see the vital signs were changing, but we were not alert enough, trained enough to understand these early signs and did not act early. The blood sugar value should be between 40 and 125. A value of less than 40 is also low, and on more than 125 is also indicating stress. So if it is less and the baby is active, you may feed the baby well and then again check the sugars. Breastfeeding is preferred over formula feeding, but formula feeding we would prefer over starting an IV line, which is a very invasive procedure as well. So if the baby's sugars correct immediately, this is better than a baby's whose sugars don't correct. In certain pre-arrest conditions, you would not have time to even do the stops. The stops takes only about maybe 30 seconds to assess. Okay, what is the sensorium? Is he warm on the periphery? Is the saturation okay? Does he have distress? Is the perfusion refill time and heart rate okay? Are the sugars okay? But if the baby is in apnea, then you don't do any assessment. You straight away start positive pressure ventilation. A baby who is actively bleeding and shocky, you try to treat with saline bolus and then get arranged blood. A baby who is having seizures may require correction of airway, checking of sugars, and trying to make sure the baby doesn't worsen from here. It's only in these pre-arrest conditions that you would not do what is called as a primary survey. So when to refer also can be made a judgment based on this. If a baby's sensorium remains lethargic for more than 24 hours, baby cannot be rewarmed despite of rewarming and the peripheries remain cold, baby is requiring 90% oxygen or retractions don't go away with a PEEP of 8, perfusion doesn't correct with saline bolus and the first shot of dopamine started, and the sugars remain hypoglycemic despite of IV fluids. Now, before we go on to the last two slides, I would like to reiterate that good care is the same world over. And after we rolled out this STOPS algorithm way back in 2003, we found that in 2006, Canada came with a program called as ACON, Acute Care of At-Risk Neonates. And this was meant to be used by pediatricians who were managing sick newborns in low volume centers. That is, they don't get sick newborns all the time. They're mostly dealing with children, but once in a while they get sick newborns. So they were asked to do what is called a primary survey before they do anything different. They don't have to do any action, but they have to spend 30 seconds in deciding, is the respiration okay, cardiovascular okay, neurology okay. This is the same as what we talked some time back: sensorium, oxygenation, perfusion. Surgical conditions we are not discussing here, glucose and thermoregulation. Same 5 questions they also had. And only after they check all the 5 questions, then they have to start taking action in each direction. And I'm going to just elaborate on what these sections were. The respiratory, that is what we talked about. Oxygenation is labored respiration. That means you would give CPAP and oxygen support. Cardiovascular means mottled color, heart rate being more, abnormal tone, jitteriness in seizures, and baby having a sugar less than 2.6, that is same as 47, and thermoregulation. So I will stop here and I will just share one scenario and ask one volunteer to solve this problem for us, and then we will go on. Any volunteer would join. It is going to be extremely easy. One volunteer, you can unmute and say, I'm in. Any intern, postgraduate, consultant, anybody. All right, you guys are shy and you think it will be difficult. I and Nisha will do the Jugalbandi together. Nisha, can you be the intern for a few minutes? Although you're already a DM cardiologist now, but I'll ask you to be intern for a few minutes. Nisha, can you unmute yourself?
Yes, sir.
Yeah. Nisha, we are having a baby who is just delivered, and this baby, the resident intern calls and says, Madam, this baby is not looking okay. And then you ask, Mone, what is the stops? He tells you, ma'am, the baby is lying little hypotonic and he is moving less. When I touch also, he is not crying. So what you will call sensorium is okay or not okay?
Sensorium.
Is okay or not okay?
Okay, sir.
All right. And when it touches the hands and feet, I think you are having some problem with audio quality. Doesn't matter. If you are having audio quality issues, I can ask somebody else to join in.
Yeah.
Okay.
Okay.
So if his peripheries are cold and you ask him to rewarm, and then the baby still feel cold to touch.
Okay.
So his temperature T is also not okay. We
Not
check
okay.
his saturation, it is 95 without any oxygen being given, and there are no retractions, no distress at all.
That's it.
So this baby's oxygenation is
Okay.
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 His capillary refill time is less than 3 seconds. It is brisk. Heart rate is 140.
So okay.
And sugar was checked and it is 62.
It's also
Yeah. So all we have abnormal now in this is two things. His temperature is not okay and his baby's sensorium is not okay.
not okay.
So the action you have to take is to rewarm this baby and then reassess his sensorium after some time.
Okay.
So this would be one approach. Now I'm just going to take one more volunteer. Anybody who is there in the audience? This is all we'll do. So it's easy. I don't want to call by names because many of you may have joined without actually joining also. It will be embarrassing. So
I
I'll ask Johnny sir then. Thank you, sir. Sir, we are sitting in the OPD and mother comes and says that this baby has been vomiting for last 2 weeks. We know this could be regurgitation also. This could be a pyloric stenosis also. And I'm going to make you to make a diagnosis. I'll just give you the stops of this baby. This baby is going on crying continuously. Mother put to breast, then also take her going on crying, not settling down at all. Baby is very irritable. Sensorium is not good. When you touch the hands and feet, baby is cold even though he was wrapped completely. Remove the baby and his hands and feet are cold. His saturation is 97, but his refill time is 4 seconds and his heart rate is 170 per minute. When we check the sugars, it is 39. So this is regurgitation or pyloric stenosis mostly, sir.
It's not regurgitation.
Yeah. So this is a very sick baby. And
Yeah.
irrespective of the diagnosis, this baby requires evaluation, admission, and care.
Intervention. Yeah.
Yeah. So I'll stop here. And this works for me. To be very, very honest, we deal with a teaching and ICU where we have DM trainees and DRNB trainees, fellowship trainees. We deal with 23, 24 weeks babies these days, thanks to the care of excellent nurses and doctors that we have with us. 400-gram babies are also there, but the mantra is the same, just the same. It is not, they will tell me, sir, blood gas is 62, CO2. I'll say, but baby is looking very active. His tone is good, he's warm, don't do anything. But a young resident, what he might do, he will try to tweak a few settings and increase the pressure here and there. I say, chhod do, believe him. This baby is having a good stops. Hmm? So this applies across OPD, labor room, and ICU. So over to the office. This is all I have to share. I would only request that whomsoever is in the meeting today, residents, if you see a baby, don't write stops and put one bracket and say everything normal. You write sensorium normal, temperature normal, oxygenation normal, perfusion normal, sugar normal, and write it honestly. In 1 week, you will be a neonatologist. And I have to quote one more teacher here, my teacher, Dr. Zulfikar, who is a father figure to me. When we were in the ward, he told me, you write ECG findings for all the babies that you see. Write the heart rate, write the P wave, write the QRS. I know there were very intelligent people also with me who felt it is demeaning to write for everybody. They only wanted to write with babies who had some WPW syndrome and all those things. But I was a little dumb type of resident, and whatever sir told, I did. But the end of this, and now after 25 years, we had a baby with atrial flutter, and my PGs were afraid to go to Sulfi, sir. He can get angry sometimes. So I told I will go with the ECG to sir. And I told sir, only what you taught me that day, I remember. Sir, P wave is normal in 1, 2, and QRS is not wide. Every P wave is having a QRS following it. That's all I know, sir. And he smiled and said, you learned the lessons during your internship well. So back to you. Thank you so much.
Thank you.
Thank you.
Thank
Thank
you,
you so
Dr.
much.
So
Thank you, Naveen, sir.
I would like a few house agents to ask some doubts or make some comments because what Sir shared is his years of wisdom. It is not only knowledge. So I think you can even share the problems which you faced while managing babies so that we can all learn together. Don't think any doubt is silly, because we all have those silly doubts. Anyone, please? We have the Houseagent coordinators also, isn't it? So they will be ready to speak at least. We would like to listen to you. നമ്മൾ മാത്രം സംസാരിക്കുന്നതിൽ ഒരു സന്തോഷമില്ല. ഇത് നിങ്ങളുടെ പരിപാടിയാണ്. You should speak.
I think Naveen sir has explained everything in such simple terms without any
Yeah.
using any technical terms. So everything is very easy to follow for house surgeons. Anybody, any queries, they can unmute and just ask.
ഇനി ചോദിക്കാൻ മടിയാണെങ്കിൽ even you can type in the chat box.
We can ask Dr. Jalil to give his opinion because he's also
Yeah.
very experienced neonatologist.
Neonatologist, yes, yes. Sir, Jalil sir is here.
Yes.
Please, sir.
Sir, what to do, sir? What to tell this? Naveen sir is a legend. He explained it in a simple manner, and I don't know how to express my happiness. This is excellent, and the basic is very important for the staffs. Almost, I have crossed almost even senior to Naveen, 38 years of neonatology. But this is, I don't know the words to express my happiness, because the basic things in neonatology, how we have to pick up the early finds and the red flags like that. He has mentioned like, for example, the temperature reading and the heart reading, how the heart reading over a period of time it is increases, and proportionately he has mentioned the capillary refilling time also, how we can bound to miss these findings if you don't have the index, I mean the ambition of learning this, sir. Sir, Naveen sir, excellent. My prayers and blessing for you, sir.
And actually, sir, I remember Dr. Naveen taught us the same thing almost 25 years back, I think. So what he told is right. He is doing it simple only. So after his 25 years of experience, still he is telling that it is very easy to manage a neonate by looking at these basic steps. Thank you, sir.
I still remember the first presentation immediately after his DM in PGI Chandigarh. I in a Neocon conference. I still remember he has spoken about the preterm babies. So this is a very excellent opportunity for the learner. And many of the house surgeons, they tend to become a pediatrician or a neonatologist after listening to such a wonderful legends.
Thank you, sir. Dr. Nisha, there is a question in the chat box. I think we can discuss that.
Yeah. What is the definition of hypoglycemia in newborn and the change in values of glucose after birth?
Yeah, it's a question that is totally not resolved because I have even Riaz, who is an endocrine expert. They like to see higher values than neonatologists. But the point is, we have something called operational threshold. And since we are dealing with a sick baby, for the safety of the baby, we have kept one value as 40. Anytime you see a value of 40, you need to act. And I will not go into details of what action to do today. It's beyond the scope of this meeting. But you may decide later on, Dr. Riyas may decide that even 50 is low, or Dr. Jalil may say even 35 I will watch. That's a different thing. But for a nurse, for resident, for postgraduate, for consultant, for court, for everybody, there is one thing called operational threshold. At 40, you must at least act, and that action may be saying, I don't want to do anything, but write it. Say, I would like to watch and see. So that will be the answer for hypoglycemia. I saw one more on the color. It's very important. We also had two aspects of S when we started, sensorium and skin color. Some lovely point that was made there. And off color, cyanosis, yellow color, these are all very important. Eventually, when we actually validated this tool and published it, we had dropped one more S from the skin to be able to make it more usable in community. And we in fact drop the sugar also, because where there is no lab test possible, we only say do at least only stop. Do sensorium, temperature, oxygen perfusion. And but point is extremely important. Looking at cyanosis, off color or yellow color is very important. Thank you for that.
So next question, how and where to check SpO2 of a neonate?
The saturation should be more than 95 in a healthy baby in all four limbs beyond 24 hours of life. This is also called as pulse oximeter screening for heart disease. But if you are looking for the baby in trying to find differences, then the best saturation is in the right upper limb, because this is what is called as preductal. On the first few hours of life, the saturation in lower limbs may be only 84, 83. That is just okay. So therefore, if you're finding a baby who is just born, or you want to check a baby for his best saturation, it is the right upper limb. But a healthy baby should have a saturation of 95 or more in room air in all four limbs after 24 hours of life.
And when to monitor RBS after birth in a high-risk baby, and how to monitor also?
Excellent. Because this is an unanswered question, but we have found a pragmatic answer to this. Is that if a baby has three biological risk factors, mother having gestational diabetes, baby being preterm, baby being low birth weight. This is for apparently healthy babies. Then only it is called screening. In sick babies, anyway, you have to check. In these three babies, we have to check the sugar levels. It may be ideal to start at least within 1 hour of life. Now that 1 hour has become very precious when you don't want to prick babies. So after 1 hour, you check sugar levels. And remember, even though there are teaching like you may stop after 48 hours or 72 hours, but there has to be one more point before you stop. Lactation is established. So if you have a low birth weight baby, sugars are well for 2, 3 values, but lactation is not established. GDM baby, third day lactation not established, don't stop sugar monitoring. So sugar monitoring is stopped after lactation is established, and we can take that on some other platform. What do you mean by lactation is established?
And high-risk babies, sir, how frequently you will check the blood sugar?
Yeah. By a practical sense, we do check 6th hourly, but if the sugar values are not optimal, they are below the operational threshold, you may check them after giving a corrective action like feeding, maybe within and half to 1 hour after that. Yeah, that's it. I didn't want to say more. So 6th hourly sugar monitoring, and if you have taken a corrective action for a low sugar within half to 1 hour after that.
Okay. Thank you, sir.
Sir, one question regarding this, because most of the time house surgeons are the one who resuscitate newborn baby. So can we say give a guideline like when to use oxygen during resuscitation?
Thank you, Riaz. Our country, Dr. Siddharth Ramji, you should know this name. Proud to be that we as Indians behind Dr. Siddharth Ramji have changed the world's guidelines on resuscitation. And the world guideline found that using oxygen was more harmful, not just less useful or not just equal to using oxygen is harmful in resuscitating term healthy babies. So term babies should be resuscitated on room air, that is only ambu bag or a thing without any oxygen use. Preterm babies may have to have some oxygen, and in term babies, after a certain stage of resuscitation, you may introduce oxygen. So in resuscitating healthy babies, no oxygen to start with. So there was some question on basic investigations for sepsis in newborn, only blood culture, no sepsis screen, no CRP, no CBC, no IT ratio, no other thing. I'm sure there'll be a lot of other opinions in the hall, but I'm willing to crush them totally. No, they're useless. Don't do procalcitonin, don't do anything. If you want to do investigation, it is only blood culture. That's it. And coming to how long you can wait for meconium, meconium generally would be passed within 24 hours. Please document carefully. Sometimes babies might have passed meconium, but you might not have written it down, and so you think it is not passed. But if baby has not passed for 24 hours, come back and look for an abdominal distension or vomiting. If these are there, immediately refer. If a baby has not passed meconium for 24 hours, but baby is feeding well, abdomen is not distended, maybe you can watch for some more time before referring the baby. Red flags, sir, for is that meant, sir, for abdominal not passage of meconium?
No, generally, because this is for the basic course for the house surgeons, and Ria sir mentioned house surgeon they are attending the resuscitation also. In a crashing baby, unexpected crashing baby in a neonate, what they should anticipate, sir?
Perfect, sir. The solution should also be there, not assessment. They should look at only 5 things what we said. Is the sensorium okay? Is he periphery cold? Is he having a saturation 95, distress, perfusion, and sugar? So this much will take about 15 seconds to finish. After you do that, hierarchically, if he is having poor breathing effort, low saturation means you will apply oxygen. If he has retractions and grunting, it's CPAP. If he is not cold on the periphery, it's warmer. And if he is having poor perfusion, saline bolus. And if he is having heart rate high, saline bolus. Sugar is low, correct orally or IV based on the situation. And sensorium should return normal within half an hour. So actually the algorithm is the same, whether you have RDS, asphyxia, the primary active is the same based on the stops.
Sir, do we need to tell them or teach them about the life-threatening orifice count or patency checking, sir, in the delivery room for this? Leave alone the expertise doing the resuscitation, the beginners.
Yes, sir.
Do we need to tell, sir?
Please go ahead, sir.
Because many times we don't consider that in those days we call it as a orifice counting, where all the orifice we have to check it, and in a girl baby whether there is a 3 opening, in a boy baby whether there is a 2. Ravikumar sir always tell check for the 3 openings in a girl and 2 openings in a boy, and of course the patency. And nowadays we don't routinely put past the nasogastric tube in a resuscitation or whatever it is. So, do we need to tell this important counting in the examination table immediately the baby born, sir?
Surely, sir. A perfect mark that after stabilizing the baby in the terms of sickness, then your physical examination should include a minimum checklist in 3 different timings.
Yes, yes.
In the resuscitation table, no cleft palate. Baby should feed. Anus should be there. Meningomyelus should not be there. And like you said, there should be these openings. Probably on the labor table, this is enough. On the first physical examination, a head to toe, AF, PF, eye, ear, nipples, fingers, genitalia, everything. And before discharge on the third day, jaundice, establishment of lactation, and preparedness of mother. These would be the 3 things that you would do before they go home.
And always check the number of vessels in the cord, umbilical cord also, whether there is a 2 openings or 3 openings or a single umbilical artery like that. That I used to tell house surgeons or the residents. This is a basic, but many times we also miss a submucous cleft or a small cleft palate, or even the imperforate anus, we missed it. So many stories are there with me.
There was
I
one
think these
question on
things,
starting
there's a
antibiotics.
question, one more question is there. In a
Yeah.
newborn with first day of fever, shall we send blood culture and start IV antibiotics?
Yes, if any of the 5 sensorium, temperature, oxygen, perfusion, temperature is already mentioned. So a baby with fever comes to my OPD, comes to all of your OPD. And if this mother is also having fever, that's situational, I would say. But if the baby is sucking well at breast, he wakes up and cries, his peripheries are warm, his perfusion is okay, I would only give paracetamol. And I'm telling you what I practice. But if this baby is not sucking well at breast, peripheries are cold, baby has a refill time prolonged, heart rate is high despite of controlling the temperature, sugars are out of range, he gets into the hospital, gets a blood culture and starts antibiotics. So it's the same stops in the OPD, same stop in the ICU, on ventilator, and same stops in the labor room.
Sir, at what point of time do we need to give paracetamol in a neonate first 24 hours, sir? Is it mandatory or is it we can wait and see? Or because giving paracetamol in a neonate, we always think twice, sir. What is your opinion? There is one entity called, we used to call it as a dehydration or inanition fever due to the reduced intake or whatever it is.
Perfectly right, sir. The sir's point is to be taken as that when you see a fever, not only in newborn, even in children, paracetamol is only going to help the symptoms and comfort of the baby. It is not a solution. So you look for the problem also. It could be due to hepatitis vaccination, the baby got the fever. It could be because of dehydration on fourth day when baby didn't get milk from the mother, not on the first day, of course. When no, but the baby gets milk on the first day. Or it could be based on a sepsis where the baby is very sick. So if the baby is having fever, while you give paracetamol or not give paracetamol, make an evaluation of the same stops. If the baby is having a irritable cry, cold peripheries because of dehydration, then paracetamol alone is not the answer.
Honestly, I never give have chances to prescribe paracetamol for the newborn, especially first 3 days. We always observe, and as you said, the stops has to be followed. And once you notify the cause, then we have to treat the cause.
Yeah. Thank you. Thank you. Thank you, sir. Johnny, I think we can
Yeah, over.
call it a
Yeah,
day.
over to Dr. Nisha. The
Thank
vote
you
of
very
time.
much, Johnny.
Thank you, Jalil sir.
Respected residents, seniors. So first I would like to thank Naveen Jain sir for that clear and crisp presentation of neonatal red flags. And that algorithmic approach of stops is really useful and it is easy to use and apply for the house surgeons. And I would like to thank the organizing team led by Priya sir, Gobi Mohan sir, my chairperson, Dr. Joni sir, and also NNF President Dr. Manoj sir, who kindly attended the meeting. And I thank Dr. Jalil sir for that comments and all, and for that usual questions we usually face from the residents and all. And I also acknowledge the presence of Dr. Shingaravedu sir, our past national vice president. I thank all the residents or our consultants, medical college faculty, teachers, and all who attended the meeting. And also the neonatologists who joined today. Thank you all. Once again, thanks to all.
Then a
Thank you,
lighter
madam.
vein, while you stop, remember stops.
Yes, sir.
Thank
Thank
you.
you, sir.
Okay.
Thank you, sir.
Bye-bye.
Good night.
Good
Bye
night.
bye.
One
Thank
more,
you, sir.
one
Thank you.
more thing Naveen has mentioned, stops, you have to write all the 5 in the case sheet. Stops normal, which is not recommended. That's a very good valid point.
That's a very, very